Hello, everyone, and thank you for joining us today. I'd like to welcome all of you, those online and here in person, to today's presentation on focused ultrasound combination approaches for cancer treatment. Today, we hear from Dr. Chandan Guha, who has wide experience using focused ultrasound in combination with radiation and other therapies to enhance the effectiveness of cancer treatment, particularly through producing a powerful and sustained immune response. A quick note for those on the webinar: if you'd like to ask a question of Dr. Guha, please submit it via the chat function. We will collect these questions until the Q&A period at the end of the presentation. And now I'd like to introduce Dr. Chandan Guha. He is Professor and Vice Chair of the Department of Radiation Oncology at Albert Einstein College of Medicine and Montefiore Medical Center. His research includes developing alternative energy-based approaches for treating solid tumors, including focused ultrasound combination and approaches that may enhance the immune response to cancer. Chandan, take it away.
Thank you so much, Jessica, and it's quite an honor and actually feel like at home at Focused Ultrasound Foundation, championing the use of ultrasound for cancer therapies. So what I thought was to just go over a brief, kind of a prelude to what we are doing, and this you can count it as a hypothesis or probably some form of reality. Today, we all live with mutated cells without having a cancer, many of us who don't have a cancer, because of immune surveillance, being able to get rid of these mutated cells with their mutated proteins and so forth. As the cancer gets diagnosed, whether as a primary cancer or a metastatic cancer, certain things have to happen in the evolution of this cancer cell. First, they try to somehow make a way to not be seen by the immune system, and that we can call like an immune escape, where we lose the mutated cells lose the ability to present their antigens on the cell surface. As the cells progress and more mutations accrue, you get an immune suppression, and the classic example of such a thing could not only be growth factors or cytokines which inhibit the immune system, but also have cell surface proteins such as program dead ligand 1 on the cell surface of tumor cells, so that now when a T cells engage the tumor, so-called mutated cell to kill it, the mutated cell instead gives the kiss of death to the T cells, so the T cells dies out. So while immune escape and suppression happens towards earlier or even later stage, you get a co-option, and the classic example of co-option is to have a macrophage lead the way for cancer invasion, as well as in chronic inflammatory conditions such as viral hepatitis. You get this ectopic lymphoid structure within the liver where you have T cells more or less guarding cancer stem cells. So you see that anywhere from you don't see me, which is the immune escape phenomena, to actively suppress them and finally make them your friends is what the cancer does from the evolution point of view. Now, over the last 100 years, we try to kill tumors by using tumor ablation. And one of the main points which I want to make here is that we are sometimes successful, other times we are not. And the main reason we would say that we can live with a diagnosis of tumor is if by chance we had this immune restoration or resurgence, which you see here, then a long-term, so what would mean is that a long-term cancer cure survivor has somehow restored immune surveillance, and it's only when ablation is combined with immune restoration, then you get a curative outcome. So with that, I would like to propose that we develop this so-called focal cancer clinic network and it's an acronym which basically talks about an adaptive use of treatment, treatment protocols, along with artificial intelligence learning, where the goal is ablative therapies for local control, perhaps also induces anti-tumoral immunity, which in turn helps local control. I'll show you an example why I'm talking about that. And finally, our main slogan should be focal therapy for systemic cure, because that's only what will lead to a survival advantage. And so there are certain terms I will be using, such as immune priming ablation, or the IPA, for in situ vaccines. And this slide essentially talks about the various outlines of my talk, which includes antigen processing and presentation with ultrasound to danger signals and reversal of tolerance and antigen presentation. So to just give an example, that when a surgeon really removes the tumor, then the assumption is that the surgeon removed the tumor and therefore the patient is cured. Or a radiation oncologist, when treats a tumor, gives higher doses of radiation. The assumption is very simple, that radiation causes DNA damage. With higher doses, you have more cure. So this paper I highlight among all other papers, including several from my own group, which essentially shows that a single high-dose ablative radiation can cause complete remission in a murine model of colon cancer. But what they did, and pardon me because this slide didn't come through that well, so what they did was that if you increase dose of radiation from 10 gray to a 30 gray, about a 30 gray single fraction, you can cure almost 90% of this colon cancer in this mouse. However, if they use an antibody to CD8 or an antibody to CD4 or any of these knockout mice, this whole so-called 90% absolute local control disappears to a 0%. And not only that, they went ahead and, just to tease us, used a 30 gray single fraction and compared that with 3 gray times 10, which is a palliative dose. And sure, palliative dose cannot cure with 30 gray single fraction. But now, just to add to a dose, what they did was they added 30 gray single fraction to 3 gray times 10 to a total of 60 gray. So one would assume 60 gray is better than 30 gray. But what really happened was that, in fact, 3 gray times 10, when added to a 30 gray, resulted in a poor control of local tumor and survival. And this highlights that many times, without unknowingly, when we attributed that a single fraction of 30 gray is curing the tumors, we actually, what happened was that it induced an immune response, and T cells infiltrated this tumor. However, a conventional fractionation, which we do in the clinic every day, give a dose of radiation, made sure that we can ablate those infiltrating T cells, which were helpful for tumor control. So with that, I would like to really focus on autologous in situ tumor vaccines. And in fact, this was one of our earliest papers in the 90s, showing that indeed tumor which has been radiated can be converted as a vaccine, as an in situ vaccine. And in this case, my argument or my rationale was that when we radiate a tumor, tumor cells will die slowly over time. And this is normally cleared up by the cleaning crew of the body, which is neutrophils and macrophages. However, the main antigen presentation role is by dendritic cells, which are normally not present in the blood. Dendritic cells are like sentinels. They are like security guards, present mostly under the skin or under the mucosa, guarding our body for any intrusion of bacteria or viruses. So our argument was that if we give a cytokine, in this case FLAP3 ligand, then stem cells from the bone marrow will proliferate as immature dendritic cells in the blood, which going through a irradiated tumor will pick up dead cells. And dendritic cells are very unique as antigen-presenting cells. They act almost like a photojournalist. They eat up these dying cells, which probably will have some mutated proteins. And that's their snapshot. They present these mutated proteins, cross-present them on their cell surface. And as they migrate to the draining lymph node, which basically is the classroom where the generals, whether the T cells are sitting there, dendritic cells present these antigens, and through a process of helper T cell followed by assassins or cytotoxic T cells, you get a proliferation of killer cells, which can then go out and attack secondary cancer sites for recognizing those mutated proteins. This paper, which was published in '99, essentially worked with a model of Lewis lung adenocarcinoma, where a primary tumor can be established in a limb, and it can be cured totally with either using radiation, a single fraction of a large dose of radiation, or surgery. So the primary tumor can be cured. But as you will see, that these animals die about 2 months later from spontaneous lung metastasis. So in this model, we wanted to test what happens if you add this dendritic cell activating cytokine after radiation or surgery. And what you see here is a summary of that about 50% cure comes after radiation plus flat C ligand. That impact goes away if you conduct this whole experiment in an immunodeficient mice. There is no cure, absolutely no cure of radiation plus flat C ligand, suggesting that whatever happened was the immunogenic means. And then if you looked at the next slide, so if you look at the next slide, what you see is that indeed 2 doses of flat C ligand does the same thing with the long-term cure, but the impact of surgery plus flat C ligand so the impact of radiation plus flat C ligand disappears when you have surgery, which removes the antigens from the tumor. Now, it just doesn't go forward, While we are trying to fix, So in the radiated animal, when you see, basically they died from massive lung mets as seen here, whereas the radiated plus flat C ligand, you see a hypercellular, lung, with the alveoli region with dendritic cells, but lung mets disappeared. And there was a control, if you re-challenge the tumor, you do get a difference between naive animals and the long-term survivors of radiation plus flat C ligand, where you found a tumor-specific immune memory. Now, just to confirm that this is not only applicable to one model, we also tested in a very aggressive hepatocellular carcinoma model, and in this case, we used a combination of flat C ligand and CD40 ligand. CD40 ligand is used normally to essentially activate dendritic cells. And as you see, anywhere from radiation or radiation plus chemo, where you get 0% survival, you get anywhere from 44% to even 84% when you combine a flat C ligand, CD40 ligand together. the liver shows tremendous amount of diffuse mets versus radiation plus immunotherapy, regressing mets, along with peritoneal carcinomatosis. And when it failed in the liver, it ended up in the lung. That's how the cancer progresses, with a massive metastasis in the lung in radiated animals, whereas regressing metastasis in the immunotherapy arm. Now, if we look more carefully about what cells are needed with FLT3 ligand, we find that CD8, CD4, CD8 in brown or red, and CD4 in green are both needed along with NK cells. However, when we combine with CD40 ligand, you seem to kind of overcome the need of CD4 cells and NK cells to some degree. Again, if long-term survivors were re-challenged with a tumor, compared to naive animals where tumors grows rapidly, these long-term cured animals had a delay in tumor growth, suggesting a immunological memory. So fast forward, for various reasons, this drug FLT3 ligand was not available for almost like 15 years, since '99. And very recently, in collaboration with Celldex, we were able to, again, resurrect this whole immunotherapy regimen. And we have initiated a clinical trial. Dr. Ori has the IND for doing a SBRT, or stereotactic body radiotherapy, for advanced non-small cell lung cancer. And there are a lot of, this is not the point of the discussion, but there are a lot of controversy about what dose of radiation to use in these trials. And we chose that we will use ablative doses of radiation, in this case 1 fraction or a 3 fraction or a 5 fraction, all which are standard radiation regimens for radiosurgery in lung. And as shown here, only 4 patients have been accrued so far, out of which 2 definitely had systemic response, and 1 had systemic response in one organ but not in another. And so examples, a patient who failed chemoradiation and immunotherapy presents to us with a large primary tumor and a small metastatic tumor. We argued that in this particular case, if in situ vaccination is our attempt, it's better to go for the smaller tumor, because this is less hypoxic and less immunosuppressive agents, myeloid cells will be there. We gave a single fraction of 34 gray along with 5 days of FLT3 ligand. 2 months later, of course, the radiated tumor has no glycolytic activity, no FDG PET doesn't light up, but also the primary tumor, which was about 5 centimeters, now is reduced to about 2 centimeters. Another example where a primary tumor in the lung with bony mets, by definition, we can only treat, in this protocol, we can only treat lung tumors. So we give, this is a large tumor, so we couldn't give a large single fraction. Instead, we gave 5 fractions of 10 gray, and 2 months later, bony mets is basically responding, suggesting that indeed local therapies, the slogan that focal therapies for systemic cure might be feasible if you can exploit in the proper way the immune microenvironment of the tumor. Over the years, I just want to show a summary that we have mostly used radiation with a variety of vaccines or flat dendritic cell activations, such as TLR9 agonist or CD40 ligand, or immune checkpoint inhibitors. And in all of that, we looked at primary tumor growth retardation with metastatic inhibition of metastasis, which results in survival, and immune assays to prove that there is an immune mechanism. What is interesting is the last 2, which is in blue. that introduces a term called LOFU, which is a low energy or intensity focused ultrasound, which, if used as a priming and combined with an ablative agent, whether it's HIFU or radiation, can result in a similar improvement in survival with reduction of metastasis and immune response. So that is interesting because this was probably the first description where you could just use various forms of energy to activate the immune systems without the aid of an immuno-oncology drug. Now, there are several limitations of such models because mostly they are transplantation models. As you know, the mouse never smoked, they never have lung disease, and one fine morning they wake up when we just implant those tumor cells, they get the tumor. So the evolution which I showed of the immune system and the tumor did not happen in these models. So when they have to design such experiments, have to be aware that you need that time for you to induce an immune response before you can start adding all the immune checkpoint inhibitors and so forth. And so the message here is that there are many forms of cell death going in the town called tumor. While we are mostly, when we do in vitro experiments, we focus on the epithelial cell death, which is the tumor cell death. However, the stroma, which consists of not only immune cells, but also myofibroblasts, mesenchymal cells, and endothelial cells, they contribute to the, in general, tumor control. And also the immune-mediated cell death, which will probably be induced after a certain time, will contribute to this situation. So with that introduction, that indeed, if done properly, both in animal models and in cancer patients, you might be able to generate an in situ vaccine from a local therapy, such as radiation. I wanted to see whether we can create a template for combination therapies in general using focal energy. The motivation is clear. The current FDA trial design is inefficient in the sense and exorbitantly costly. Usual response rate is about 20 to 30% in randomized trials, so majority of my patients don't benefit. And so there's no hope with the current design for an adaptive treatment planning. So what we proposed was something which we are calling a IPAC trial, and it really has 3 phases. So if a patient who has metastatic disease gets diagnosed, at that time, while we are giving the slides to generate pathology and exome sequencing and all kind of omics, we have one thing with us, which is basically imaging. And what I would argue at the priming phase, that the imaging and blood markers probably make the most sense. It's like the genotype of a tumor is only good to make a certain phenotype. And there are certain similarities of how the tumor has to behave with respect to metabolism, with respect to perfusion, with respect to how dense the tumor is, or what type of collagen matrix the tumor has. And many of these will depend on the mutations. However, several mutations can point towards the same pathways. So by looking at imaging parameters, one can perhaps focus on how to do things. So at the priming phase, you might not be able to kill the tumor, but you might be able to do improved drug retention or perfusion or distribution in the tumor, or improve immune recognition. And essentially, these 3D map of tumor from imaging might be able to point that out. So just to give some examples, tumor perfusion as a priming agent. This is a paper from Rakesh Jain in Mass General, and all they're seeing is in blue in a particular tumor which has collagen matrix. By giving an angiotensin inhibitor, they can improve, in this case, basically more drug distribution of doxorubicin, which is a standard drug, or 5-FU in 3 different models of breast cancer, and improve survival. So if you just give angiotensin inhibitor, which is a normal FDA-approved drug, and it increases vascular supply, you might be able to improve, effect of the chemotherapy. Now, of course, Focused Ultrasound Foundation have been a leader in trying to improve drug distribution. There was a recent, webinar which looked at blood-brain barrier, in this month, and as a recent review article from Seattle from Dr. Koklova's group shows that microbubble and ultrasound can improve perfusion priming, and essentially there is a human clinical trial which was using ultrasound and microbubble in this case with gemcitabine, again showing that if you do sonoporation with gemcitabine, maybe there might be some improvement in survival. So clearly perfusion is important. But what about immune priming? And so immune priming can be systemic or local. And I will give you an example of pancreatic tumor. I'll try to show that if you have the sequential combination of priming, ablation, and consolidation, which is the immunotherapy portion, then you would be able to do better control. In this particular case, Dr. Mani, who was our chief resident and won this, had this ASCO Young Investigator Award, looked at pancreatic cancer, which has basically 0 response in most immunotherapy and checkpoints. He was since he was his point was that the first step, which is immune escape, if the cancer cells do not express the mutated antigen with their antigen receptor, HLA, then what good it is to induce a lot of T cells against them. Now, of course, pancreatic cancer has other problems, including T cell exclusion or T cell distribution, but we just focused on antigen presentation in this model. And what we saw that if we look at the the Cancer Genome Atlas, TCG Atlas, and have in the x-axis all different type of tumors, and in the y-axis genes which are related with antigen presentation, HLA, proteosomes, transporters, and so forth, you find that pancreatic cancer perhaps underrepresents or underexpresses, has a reduced expression of these genes. Now, one can see that for immune surveillance to happen, the T cell receptor has to be active and binding to this peptide in the MHC, and it requires multiple steps from proteolytic breakdown of peptides to transporters and presenting molecules which has to be active. There is only one way you can knock down 10 or 15 genes at the same time, by doing epigenetic suppression, whether through methylation or acid HDAC. And what he found was, again through the TCG Atlas, that the pancreatic tumor overexpressed HDAC. So the idea was that if I inhibit HDAC, can I now make the tumor cells present their peptides in HLAs? And to our surprise, that the most common pancreatic cancer model, which is used in mouse, we found that almost 100% express HLA or MHC. Now, we thought that perhaps this PANC-O2 model do not express the same genes or mutations as the human models. And so we took a GEM mouse, in this case from University of Nebraska, which has the KRAS G12D mutation. And as soon as you have these mouse model cell lines, the HLA goes away. So therefore there is some link about the epigenetic suppression if you have the human specific mutation in the mouse, then you get the impact. Now, radiation oncologists take credit that radiation induces HLA or MHC. And what we see here is that indeed, in presence of this KRAS mutation, somehow we are not able to overcome the reduction of HLA in these tumor cells. But as soon as we start giving a HDAC inhibitor, in this case a very commonly used HDAC inhibitor, SAHA, you start inducing HLA, MHC. So what is interesting is that our goal was not to use a HDAC inhibitor to kill the tumor. It was just to use the dose to induce the antigen receptor on the cell surface. So now you could try to see the concept of priming, ablation, and consolidation. So if I use a HDAC inhibitor, in this case for immune priming, to induce HLA or antigen receptor, in this case MHC, on the mouse cancer cells, and radiation as an ablative agent, and checkpoint inhibition as a consolidation or immune check, or immunotherapy, what you see is that while individually they did not make any difference, but together they have an impact, giving some credibility to this concept of sequential use of agents, where priming would be to either prime vascular supply or to prime immune recognition. Ablation will be to cause immunogenic cell death, and then consolidation will be to create on that foundation of in situ vaccine to amplify T cell response. So without going into detail, at Einstein we have this project Anergy, where we are using ultrasound, histotripsy, radiation, electroporation, radiofrequency, and now microwave, along with standard medicine like digoxin or metformin, to see what is the ideal combination therapy which you need. What type of energy can be combined with a drug or energy to resulting in this activation. So over the next half of the talk, I'm going to focus mainly on acoustic priming and try to make a plea that indeed there is a unique opportunity of using some spectrum of the ultrasound spectrum. Remember that this is, for a patient, it's very healthy to say that this is the same ultrasound which sees your tumor, also sees your baby. And now that ultrasound can be, the spectrum can be increased to a form which can cause ablation in HIFU. And tumor cells die within 4 or 5 seconds by coagulative necrosis. But in between the spectrum, there are energy spectrum where the goal is not to kill, but the goal is how best you can prepare these cells for immune recognition. So these slides, borrowed from Naren Shangvi, essentially shows that focal ultrasound can really generate very high levels of energy, which can cause not only imaging and treatment, a quick tissue destruction, almost instantaneous destruction within 5 seconds. And so over the years, this HIFU, MR-guided focused ultrasound, and transurethral ultrasound ablation all have been used. What we are talking here is some terms which have been mostly used in our lab as LOFU, low energy, or sonic stress, or acoustic priming. And all of them don't cause tumor death directly, within a few seconds. What it does is something which we wanted to look. So using a laboratory machine, in this case a TIPS unit, with a megahertz of 1 megahertz, but as you see that you can really play with different conditions, and I'm not going to go into this detail of these conditions because it will vary from tumor to tumor and model to model. However, what I want to stress is that we are aware of the thermal energy versus mechanical energy. And what is interesting is that majority, our focus had been if we can cut down the treatment time. And in this particular, we have used in basically 1.5 to 3 seconds in each focal point. So if we basically try to see what really this LOFU, what is the stress of LOFU? And I do not want to call it a ER stress or a UPR or a immunogenic stress. I just named it as the sonic stress of LOFU. And just look at prostate cancer cells, various cells, and try to see what is similarity in a RNA sequencing, just to see what genes are induced 6 hours and 24 hours. 6 hours is the primary time point of this. And what we found is that the first group are a lot of chaperones which are involved in various stages of protein folding. Not just chaperones, but also proteosomes and autophagy genes which are induced. There are other genes which we are now looking, the significance of induction of receptors and cytokines, but there are apoptosis regulators and peptidase. So transporters, peptidase, regulators suggest that perhaps if you do a gene ontology, perhaps LOFU or ultrasound disrupts de novo protein folding, which in the olden days can be called as DRIPs, right? The defective ribosomal product, or results in protein misfolding of already proteins. And we then went ahead and looked at a whole heat shock protein and molecular chaperones, and we found that indeed they are induced, but there is a transient induction which over time goes down over 24 hours. So there is a window where these chaperones are really high. And so for all our subsequent experiments, we tried to combine LOFU within that window of 24 hours. In case of radiation, we found that LOFU actually inhibits the phosphorylation of STAT3, which is a radioresistant protein. And so we used LOFU within 2 to 3 hours of, we delivered radiation within 2 to 3 hours of LOFU. However, any other ablative agent, whether it's chemotherapy or HIFU or any other forms of energy which are ablative, can be done within the first 24 hours. And what are the trademark of this immunomodulation? Taking 3 different cell lines, the pancreatic cancer, prostate cancer, and lymphoma, what we see is that there is an increase of translocation of surface calreticulin 6 hours, 24 hours, and 48 hours over time. And obviously, there is a big difference between lymphomas and pancreatic tumors. However, the trend is the same. So even though different cell lines, whether it's pancreas or prostate or lymphoma, will have different actual absolute value, but the trend is same. And also, there is induction of HSPs. HSP 70 is just an example, but other HSPs also go up. Now, this is really a plot, a summary of what my graduate student, Dr. Karen Skelina, is working on, and essentially shows that we can look at immune modulation by translocation of stress proteins from the endoplasmic reticulum to the cell surface, as well as stimulatory molecules, death receptors, and inhibitory receptors. And there are some cell lines, breast and prostate, which has very high, and others which has modest. But overall, everything showing the same trend of induction and translocation of stress proteins as a signature of LOFU treatment. So one could say that whether it's chemotherapy or radiosurgery or chemoradiation, or HIFU, LOFU, what it does is it prepares the translocation of calreticulin as a eat me signal, and the release of HMG-B1 or translocation of heat shock proteins as a danger signal for dendritic cells to get attracted to these treated cells. And so now dendritic cells can eat up your dying tumor cells appropriately. Just to show some examples, this is an example where we combine LOFU of a prostate tumor with a Listeria PSA vaccine, And while the Listeria PSA vaccine had 3 cures out of 15 tumors, LOFU plus Listeria PSA had about 13 cures within the 15 animals we treated. This resulted in, essentially ELISpot for interferon gamma, as well as PSA-specific tetramer staining, which essentially looks at CD8 T cells against PSA. So we show that indeed ultrasound could promote this immune recognition in a better way and essentially prepare tumor antigens for these dendritic cells to be present to T cells. And now you get a robust immune response when combined with a vaccine. The vaccine was essentially used because when you just use an ultrasound, you don't know what antigen they are presenting. And the vaccine was my readout to show that indeed you can generate an immune response to a specific antigen. So that brings to my last topic. In this case, I'm talking of a tumor draining lymph node. Normally, as surgeons or as radiation oncologists, we sometimes tend to think that these draining lymph nodes are like a mesh, like a sink where the tumor just gets stuck in a mesh. However, as you will see that there are, specific examples where you could see that as the tumor grows, the draining lymph node is converted to an immune privileged site. It's what we call immune co-option, that the tumor is somehow secreting factors, which is essentially reprogramming the draining lymph node as a immunosuppressed or anergic site. So the goal, so as shown here in 3 different models in a B6, C57 black 6 melanoma models, wild type or OVA expressing melanoma or TERP1 mice, if T cells from the draining lymph node are non-specifically activated using 2 signals, anti-CD3 and anti-CD28, what you find is the amount of IL-2, which is a growth factor. When T cells are activated, they grow using IL-2 as their food. When you look at the amount of IL-2 which is expressed in draining lymph node of 3 different melanoma models, it's always the least. Whereas in the same animal, in the non-draining lymph node, IL-2 is reasonably good. So it basically shows that the tumor has somehow paralyzed or stunned the T cells within the draining lymph node, so that now it can progress in the, it can basically go in the draining lymph node and grow and therefore metastasize. So in this model, we wanted to treat a flank melanoma using LOFU, and then look at the draining lymph node. And what is shown here, untreated versus LOFU treated, there is a reversal or reactivation of these T cells with production of IL-2. So a T cell activation and energy can be looked at with restimulation assays as shown in this cartoon. With restimulation, T cells proliferate, but anergic T cells don't. And this whole pathway is mediated by transcription factors, which Fernando Macian in our institute has been looking into, as these transcription factors, each GRAIL, which are responsible for the T cell energy transcriptional program. So we wanted to see, to just prove the mechanism of action, whether these transcription factors which are associated with the T cell energy pathway, what happens to them in this model. Indeed, untreated tumors shows that GRAIL, EACH, CBLB, all of them are hyper or overactivated because of the energy. As we do the LOFU treatment, we start seeing that in the draining lymph node there is a reduction of GRAIL or CBLB. So it basically shows that LOFU somehow overcomes the transcriptional paradigm or transcriptional program of T cell energy. So it comes at the highest level. Next, we wanted to see that if we take splenocytes and give them only one signal and tolerize them artificially. So in this case, as you see, control cells, lymphocytes, when activated by two signals, give rise to IL-2, but anergic cells don't. In this model, if I take dendritic cells, anergic T cells, and lysates, which has the antigen recognized by these T cells. So in this case, untreated lysate is basically freeze-thaw, almost how you do for cryotherapy. Freeze-thaw the tumor cell which expresses the antigen, feed it to a dendritic cell, and look at a readout. And you find that in case of untreated lysates, you are not able to overcome the Anergy. But when you use a LOFU treatment, 24 hours later, prepared lysates, and feed it to a dendritic cell, you somehow are able to overcome Anergy. So it would mean that besides tumor antigen, you need something as an adjuvant, and perhaps ultrasound provides that adjuvant to overcome the tolerance. So all this mechanism is good. Now, how does it impact actually tumor cure? So we again took this metastatic melanoma model, and without treatment, it grows rapidly. With LOFU treatment, which is non-ablative, it has no impact on tumor growth alone. When we use radiation, I call it complete response followed by regrowth. So that's like a ablation agent, but over time, because the immune system is suppressed, you are not able to have a long-term cure. A 1 month growth delay for a mouse is a great growth delay. I mean, that's highly statistically significant, and that's the standard of care we use in patients. However, once we combine LOFU, which by itself didn't do much, and therefore defines priming, which by itself doesn't do much, in combination with an ablative agent, now you get, long-term cure. And the reason it's cured is that in a nude mice also, even though there was some retardation, but there was no long-term cure, suggesting it's an immune process compared to a wild-type mice. And at that point, if you look at the metastatic lung, LOFU plus radiation totally suppressed metastasis in the lung compared to radiation alone. If you look at day 7, your favorite time point when you look at activation phenotype, what you find without treatment, mostly these cells, whether it's CD4 or CD8, they express CD62 ligand. CD62 ligand is needed for homing of resting or naive T cells on lymph nodes. When they don't express CD62 ligand, they can then move and patrol the blood for basically their activated phenotype. Both in CD4 and CD8, you find that after LOFU and radiation, primarily the y-axis, which was naive cells infiltrating the tumor, now have been activated, most likely by incoming new cells which have been attracted to antigen release. So with that, the last example that you can perhaps use this as a means to select drugs that LOFU alone with untreated in these 2 models of prostate cancer doesn't significantly reduce growth, but a toxic drug, in this case HSP90 inhibitor, when combined with LOFU has better growth retardation. And in these models, what you see, unlike radiation and chemotherapy, stem cell marker goes down, which would suggest that ultrasound perhaps either kills them or makes them differentiate. So with that, I want to leave with this summary, that acoustic priming perhaps can be used as a radiosensitizer, chemosensitizer, or immunosensitizer, or as a sensitizer for ablative therapies in a unique way, that they are not classic sensitizers which increase a cell kill directly, but they, by promoting an autologous in situ vaccine-like effect, they impact tumor growth and control. So with that, I like to thank my focal team, a lot of students over the years and associates, And however, two key collaborators, Fernando Macian, with whom I do all the Anergy work, and Steve Almo, I have not shown any of his work, but with whom I am trying to develop precision immunotherapeutics, which can be exactly for the antigen for which we want to activate the immune system. Medical physics is critical, and my clinical team who has done those trials. So with that, I will take any questions you may have. Thank you.
Thank you, Chandan. That was very illuminative. You showed some really profound effects of, if you will, presaging the radiation therapy with the LOFU, and that really gave a lot of therapeutic effect there. So which implies that the LOFU and radiation are actually releasing different maybe different repertoires of what we call alarmins, which are really the heat shock proteins that you're describing, and related family members that really activate the dendritic cells. Have you had the opportunity to really try and get an idea if there really is a different repertoire of innate response to LOFU versus radiation therapy, and even expanding beyond that into the realm of looking at mechanical versus thermal energy when you change the parameters of focused ultrasound?
So Tim's question is very profound in the sense that it basically is another whole talk about what does energy do in the setting of in situ vaccine. So those who are following the in situ vaccination literature, radiation and various chemotherapy can induce what are known as danger-associated molecular patterns, molecules which essentially tell the immune system that there is a danger. And classic examples from the French group had been ATP, HMGB1, and calreticulin. Now, while that's exciting, but that's not the end all. So it's clear that what Tim is suggesting is that how do you judiciously choose one energy form with another energy form? For example, does electroporation, radiation, and ultrasound all have the same response? And even for a single energy like ultrasound in different spectrum will have different impact. So for example, sonoporation type of ultrasound has a totally different impact than what and vice versa, even with radiation. So what we found is that in radiation, you primarily get a oxidative damage as your primary modality. And again, the protein unfolding is not that prominent in radiation, unlike ultrasound. So what is the advantage of ultrasound is that unlike radiation, it's non-ionizing. So if we all are looking for an energy device, or we are looking for energy for immune priming, you know that there was never one vaccination attempt with one tetanus toxoid or hepatitis and you got one shot and you were immunized. You never did. And why is then our design of in situ vaccines just one shot, look for an abscopal effect? That totally defeats the purpose. The whole idea could have been 2 to 3, vaccination attempts should be made. And in that, ultrasound can be repeated as cycles because it's non-ionizing. Whereas radiation is a one-shot deal. You treat with the dose and you are done with respect to ablation, because the same tissue cannot take more doses of radiation. However, the same tissue can take more doses of ultrasound. So practically, there is a big difference. Mechanistically, ultrasound perhaps signals these exosomes as well as membrane-bound danger proteins, that's HSP70, BIP, which is a glucose-related peptide 78, HSP90, all these proteins. So it's not just calreticulin, it's more or less any chaperones are kind of translocated to the cell surface, which is, with radiation you see calreticulin but not necessarily the others. So I think that there would be a general difference, and our lab is essentially looking at if you do electroporation, the ER stress perhaps is through calcium channels. If you do ultrasound, the ER stress is perhaps through the stress exosomes. And whether the stress exosomes of ultrasound are very different than that of radiation, which is filled with oxidative damage.
We have a question coming from online, and it's kind of, you were just explaining different effects between radiation. Let me.
Yeah.
So the question is, how does the priming differ between LOFU and traditional or rapid hyperthermia?
A very good question. So there are two parts to this question. One part is that can hyperthermia have an immune priming effect? We know that hyperthermia does have immune priming effect. I mean, from the time of those, whole body hyperthermia to traditional hyperthermia. The only problem with those hyperthermia regimens have been how to make sure that the whole tumor is treated, and usually the treatment process needed 30 to 90 minutes. This LOFU essentially is a sudden shock, and it's right now at a focal point we are just talking about few seconds. There are a lot of technical challenges of developing such a machine, and we are facing them as we speak. So what we want to do is that, unlike hyperthermia, where the goal was primarily to kill the tumor using either hypothermia alone or hypothermia with chemotherapy, and needed a treatment time of 60 minutes to 90 minutes, we want to cut it down to less than a minute or less than 5 minutes. Almost like how radiation works in the clinic, because there are many practical issues of using a prolonged treatment time. And it may be that this sudden shock has a better impact of not killing the cell while allowing the immune response, the priming to happen.
Thank you. One question. If you look at the LOFU for priming, there are a number of different ablative techniques that you can use. Have you done any inquiries looking at using multiple ablative ones together to try to enhance or expand the priming benefit?
Yes, that's absolutely what we want to do. In fact, the so-called Project Anergy in our Institute for Oncophysics is essentially looking at what should be priming and what should be ablation, and what type of energy or drug can you use for ablation after priming. What we have seen so far, that LOFU successfully primes for chemotherapy, successfully primes for radiation therapy and HIFU. And now we are going to compare that with also microwave. And so microwave is also another form of thermal, energy basically. And the goal is that if, I didn't show data, but when I used instantaneous ablation, such as HIFU, where within 5 seconds you have ablation, you get a tremendous release of heat shock proteins in the blood. However, when the tumor cell expressed a particular antigen, let's say ovalbumin or PSA, then looked at gamma ELISpots or looked at CTLs after cycles of HIFU, what we found is that T-cell immune activation is very rare after HIFU. However, there is a very high amount of humoral immune response. So if you just look at the serum of this patient, of this animal, you take the serum and take HIFU-treated proteins, they bind. So essentially what these microwave or HIFU or these instantaneous ablative agents do is almost like prepare a SDS-based gel in the body. Essentially denatures all the proteins, the omelet is instantaneous. So all the proteins of your cell are omelet now, and they are released as denatured proteins, almost how you cut a SDS page band and inject in a mouse, you get a good antibody response. But majority of these antibodies are again cytoplasmic proteins, which are denatured, which therefore are useless with respect to tumor control. However, when we combine LOFU and then did the HIFU and repeated it 3 times, we started seeing specific immune response to tumor antigens present within the tumor.
Thank you for the really interesting talk. So you show that you got a very large change in the number of activated T cells in the tumor following priming with LOFU. Do you have a sense of whether that change is due to activation of existing T cells in the tumor or whether that's migration of newly activated cells?
Well, that's a big question, but my assumption is that the dose of radiation which I'm using kills away all the existing tumors. Now, I can't think of another ablative agent, maybe chemotherapy, but most other ablative agents such as microwave, HIFU also kills the tumor. Radiation doesn't instantaneously kill the tumor, but kills the lymphocyte instantaneously almost within 6 hours after dosage. There is a big difference. In fact, radiation kills the CD103 plus dendritic cells. Okay? And so for all of us who are trying to use radiation as a magic drug, there is no antigen presentation. So that's why the flat C ligand is showing such great results compared to, let's say, radiation plus anti-PD-1, which is not showing good results. So what I believe that what LOFU did was to really main target have been mainly the lymphocytes, epithelial cells, tumor cells. We right now are in the process of looking at what is the impact of LOFU on macrophage and dendritic cells, because that's another group which might have a role to play with the ultrasound. Our work has solely focused on the tumors for now, but I believe that as shown in the draining lymph node, that there would be some distant effect of using ultrasound or paracrine effect or at least regional effect. And so the new T cells which come from the body is critical. And your question also holds true for a variety of rationale of how to combine anti-PD-1 or anti-CTLA-4. Are you first amplifying the pre-existing T cells and then do LOFU plus radiation? Or do you do LOFU plus radiation and then amplify the T cells? Or both, sandwich. So therefore, right now we believe that the majority of the activated phenotype is coming from elsewhere because of the radiation. But ultrasound alone, I don't know.
Do you have any other questions in the room? Okay. Then with that, this concludes today's webinar. I thank you all for joining us today, and stay tuned to our newsletter and our website for invitations to future webinars, as well as a link to the recording from today's webinar. Thank you all.